Hi, welcome back to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor for JAMA Network Open.
And I'm Mike Berkowitz. I'm Electronic Editor for JAMA and the JAMA Network.
So thanks for joining us. We're going to dive right in. Our first paper is Calories Purchased by Hospital Employees After Implementation of the Cafeteria Traffic Light Labeling and Choice Architecture Program by Dr. Ann Thorndike and colleagues. And we're happy to announce we have Dr. Thorndike with us. So welcome.
Thank you.
So why don't you tell our viewers a little bit about what you did in the study here?
So this is work that we've been working on for a while at Mass General Hospital. The program originally started back in 2009 when I worked on an employee wellness program and working with the Human Resources Department. And at the time, the idea about traffic light labeling was being tossed around. And when it came down to it, we decided that if we were going to implement this program, we should study it. That was my feeling, like that there's a lot of good ideas out there that never get studied. So in order to implement this project, I got a small grant to not only develop the traffic light labeling program, but to analyze it. And so what we did is we developed the traffic light labeling program and identified all the foods and beverages as red, yellow, and green. And then what we did is had a baseline period where we collected data on what people were purchasing, but there were no labels in place. The labels were put into place starting March 1st, 2010, and we had only labels for 3 months. And then we did something where we moved the healthy items to be more accessible to people and visible. We called that choice architecture, and made them more convenient. And we did that for 3 months. And so when we first analyzed this work, we just looked at the proportion of red, yellow, and green that people were purchasing. And we looked at that over the 9-month period and then over 2 years. At the time, we didn't have a database with all the calorie information. This was a huge amount of work to get all of this into a database that we could analyze and manage. So in the course of another project, another randomized trial that we're currently working on, we did all of this work. And so we went back to analyze to see what happened with calories. That I think changing the proportion of red, yellow, and green purchases is one thing, but it doesn't. People intuitively don't understand what's happening with the calories, and that's going to be you're going to be able to directly translate to weight. So what we saw is that not only did people purchase fewer red items and more green items, but they actually reduced the number of calories that they purchased over 2 years.
Okay. Yeah, and Figure 1 puts that together pretty well. You've got a nice and fair and fairly objective y-axis there, so it's not totally dramatic here, but it looks like it led to about a 6% decrease in calories. Which sounds like it doesn't sound like a lot, but what does that mean?
So in Figure 1, what we're showing is the calories per transaction for the entire cohort of employees that use the cafeteria over the 2-year period. So 6% decrease in calories represented a reduction of 35 calories per transaction. So sometimes people make more than one transaction per day. And actually, in employees who purchase frequently, you'll see that they'll buy something for breakfast and for lunch. So that could be up to 70 calories a day for those people. But I think that the piece of this Figure 1 that I think is most important is that the reduction in calories took place mostly with the red items. And so these are the items that were high in saturated fat and unhealthy ingredients like sugar. And so that not only were we seeing a reduction in calories, but we were seeing an improvement in the dietary quality of what people were purchasing.
Yeah, that's really fascinating. And I think if the math is right for the frequent purchasers, the estimate was that they lost about 2 kilograms at 2 years, so which is about 5 pounds, which just by kind of simple day-to-day choices is fairly impressive amount of. I'd be happy if I could lose 5 pounds without doing much different in my life.
Were those estimated based on the kcals reduction, or was that a measurement?
Yeah, so I'll explain more about that, because that's just a hypothesized weight loss.
Right. Sure.
And so, what the argument would be against that would be, well, we don't know what people were doing otherwise. So the hypothesis that we're just estimating and saying, if you made no other changes in your life other than what you were doing in the hospital cafeteria over 2 years, then this could translate for those people who are frequent purchasers into a weight loss of about a little over 4 pounds. And so, of course, that's not probably real life, but we do know from other epidemiological studies that people on average gain 1 to 2 pounds per year as an adult. And so what this is doing is helping to prevent that annual weight gain that we tend to see as adults. I think that it's important to understand that this is not a weight loss program. This is a weight gain prevention program. This is helping people to not gain weight.
Yeah, which unfortunately, I think a sad reality of our current food and health environment is that it's just so, I don't know, hard to make good choices. I'm pretty well educated. I have, decent amount of resources. I live close to Whole Foods. I'm married to a dietitian with a really good healthy attitude towards healthy food, and it's hard for me to make good choices. And one of the things that always strikes me about looking at these papers is there's, in 2009, 22,000 employees at Mass General, plus all the patients and visitors who are coming through every day. So that's, a potential for a pretty big footprint of impact here.
Yeah.
So one of my pet peeves in the nutrition movement is this move towards plant-based food where they make a lot of products that with coconut oil and palm oil, which is high in saturated fats, for example. So I was wondering how you classified, like, French fries as a vegetable or, a fried food with a lot of fat. How did that come out in terms of red, yellow, green and your guidance towards consumers in the cafeteria?
Well, French fries would be a red. I mean, they're not counted as a vegetable.
Good.
But the way that our traffic light system works is that we have positive criteria and negative criteria. And so the negative criteria in this system is based on saturated fat content and the over a certain threshold of calories, if depending on whether it's an entree or a food item. So in order to be green, it has to have a more positive qualities than negative. So it has to be that the fruit and vegetable as the primary ingredient, a whole grain as a primary ingredient, or a lean protein. So things end up being yellow that might be a fruit and vegetable that had some sugar in it, or that that type of thing. They balance each other out.
Got it.
Yeah.
Useful. And then a lot of times we see with some interventions, you squeeze the balloon in one area and it kind of expands in the other. Do you have any information or sense about leakage? That is, people are eating more healthy in the cafeteria, but then at 3:30 p.m. checking something out in the vending machine that's less healthy to kind of make up for the calories they saved, just behaviorally. I'm wondering whether there's any sense for how that's performing kind of throughout your institution.
So I don't have any information about the vending machines. At this point, we actually are able to collect data from all of our cafeterias. And actually, we just recently published a paper that looked at the quality of cafeteria purchases and compared it to their healthy eating index score that we measured with 24-hour dietary index. We also showed in this other paper that the healthfulness of what people were purchasing was related to their rates of obesity, pre-diabetes, and hypertension. So there's pretty good indication that what people are purchasing in the cafeteria is related to their overall dietary quality. Because that is something that has been brought up in the past. That's the reason we wrote that other paper.
Awesome.
Yeah, no, this is really interesting stuff. I mean, to me, to build on your point, my biggest pet peeve is how easy it is to have misleadingly healthy things. Like we have one of the places in my hospital is what I think of as fake healthy. It sounds like it's good. It's like a turkey sandwich with avocado, but it's really an 800-calorie grilled cheese. And so, the easier it is to make healthy choices, especially when you're working a busy, long day. With the frequent purchasers you mentioned in your paper described as, having tended to be the lower education, less skilled workers, et cetera, who, may have fewer options otherwise. So the better healthy choices, the easier it is to make them. So stuff we like.
Yeah, and this is awesome work. We've talked a lot in these broadcasts about kind of behavioral economic strategies, nudges and opt-ins or opt-outs. And so this is another example for our viewers and listeners. And it really seems to be taking hold. So congratulations on a great study, and thanks for submitting it to the journal.
Yeah.
Great. Thank you very much.
Sure. Thanks for joining us
Take
today.
care.
Take care.
What's next, Seth?
All right, so moving on, we are going to do a slightly long, but not as long as last time, table of contents rundown.
Yes.
So first up, we have another great aortic, catheter-based aortic treatment repair.
Okay.
So this is another one from Canada, looking at AAA repairs, elective AAA repairs. So EVAR, so endovascular versus open repair for AAAs. They looked at 18,000 patients in Ontario from 2003 to 2016. They did some more advanced stuff. They propensity matched 4,000 of the patients against each other, and basically looked at outcomes. Some of the outcomes were up to like 12 years, which is pretty interesting. But some of the top line data they have was survival was higher at 1 year for EVAR, for the catheter-based therapy. It was 91% versus 94%. Major adverse cardiac event-free survival was also slightly lower at 4 years, 70% versus 73%. And the one downside was a slightly higher reintervention rate in endovascular repairs at 46 versus 42%. But overall, when they tracked them out, basically every patient in the database as long as possible, which was, again, up to 12 years,
Right.
Basically had the exact same rates of the important things like reintervention long-term and secondary rupture, which is around 1%.
Right.
And this is interesting, especially because it's a pretty older population with comorbidities. The average age is, I think, 73. So I'm not a surgeon. I hopefully, as far as I know, don't have any aortic problems yet.
And you don't plan to do any surgeries?
No,
Yes.
no, definitely don't plan to. But you never know.
Right.
I mean, people get locked in elevators. But it looks like endovascular repair for the appropriately selected patients does well.
Right. So that's exactly how I read it. And I was kind of surprised. These authors seem to put a negative spin on this, saying that endovascular aortic repair wasn't associated with a long-term survival benefit. They kind of framed their conclusions as if this was a set of disappointing results, when in fact, I found there's no difference except for the re-intervention for the EVAR patients as being incredibly good news for yet another minimally invasive technology that we would think is probably reducing short-term morbidity compared to an open procedure, and with a more generalizable data set here.
Yeah, and again, I'm a little out of my expertise on this, but I would expect that there's probably more patients who are eligible for endovascular repair because, if you're sicker and have more comorbidities, getting a big open repair is potentially more dangerous, et cetera.
Right, but that's the exact reason why this needs to be studied, because a sicker population going into a less morbid procedure may still have complications comparable to a healthier population going into a more morbid procedure.
Right, exactly.
And so using these large data sets to confirm that in community and clinical practice, these things that are working well in highly trained medical centers are in fact as beneficial and safe or safer is always valuable.
Yeah, absolutely.
Okay.
All right, next up, this is a look at accountable care organizations, which very briefly were started kind of in one of the many interventions as part of the Affordable Care Act and the Center for Medicare and Medicaid Innovation. Basically it's not quite bundled care, but
Yeah.
ostensibly it's kind of bundled fee-for-service care, is an easy way to put it. And they looked at what rate of specialist versus generalist visits the patients had.
Well, it's meant to incentivize care coordination and quality between multiple team players and units of an organization.
Right, exactly. And they basically, so they looked at 620 different ACOs from 2012 to 2017 with a total of 1,800 ACO patient years, which I always love those numbers like that. Those like integers that don't mean anything. And basically broke them up into, I don't know what the word for this, dodecasiles, 5% groups.
Okay.
So from 35, 40, 45, et cetera, up to 50% specialist visits, and basically try to analyze.
Are they not quintiles?
No, quintiles would be 5. That would be 20% groups.
Got it. Okay, 5
So
divisions.
these are
every
20
5%.
divisions. Yeah, every 5%.
Okay.
And basically to see what's the mix if you're spending too much money on specialists, but potentially getting better, more focused care, or not enough patients have access to specialists to get advanced care they need, or do specialists end up being, doing too much or too expensive care, et cetera, and nobody really knows because there's so many different levers getting pushed that are all complex and interactive. And basically they found essentially a V-shaped curve where the correct answer was in the middle. which isn't terribly surprising.
Right.
But basically, patient ACOs that had patients with the lowest specialist visits did basically cost a ton more. It was the 40 to 45% specialist visits that did the best. It was $1,000 or $1,100 more per year per patient compared to in the lowest groups, and $750 more per year in the highest specialist groups. There were also pretty linear relationships between the more specialists the patient saw, the fewer ED visits, fewer hospitalizations, and fewer SNFs utilized. But the more you saw specialists, not surprising, the more MRs you got. More specialists, more MRIs.
So this is kind of important. We're all proud of what we do, and we all think probably we're the physicians to administer the care. And there's been a decades-long kind of conversation, if not an argument, about whether the primary care docs should be really providing most of the care and actually save costs and expenditures, or whether specialists are the most appropriate people. And of course, it's not either or. The answer we knew probably intuitively before this study was somewhere in the middle in collaboration. So this was kind of surprising results that a certain kind of proportion of visits attributed to specialists are associated with the least health expenditures. So, that is a feel-good message about collaboration between colleagues. And hopefully primary care handling a lot of things. And you could kind of read in a lot of patterns here, suggesting, for example, that the frontline docs are ordering a lot of tests, to look at one of everything, and then that's bumping up costs up front. Because they feel like they either don't have the specialist support or somehow don't want to get the patients there for whatever reason. They're driving up costs, but or that the specialists are more judicious, except for MRIs, maybe in these set of findings in terms of what they can order. So it's hard to read out of this, but it's a feel-good finding that says that if we work together, probably that's the direction for both quality of patient care and reducing expenditures.
Yeah, to steal from a colleague, this kind of care coordination is essentially like making mayonnaise. There are certain different ingredients that are totally distinct, and then at some point you get the right mix and it turns into something completely different and strange.
I see. You're speaking like a nutritionist again. Okay.
No, my wife hates mayonnaise, and not just for the nutrition reasons. The flip side is we're not going to cover the other paper. There was another paper in this release on coordinated care in ACOs that showed no benefits. So, okay, solid safe for that.
Yeah.
Next up, shifting gears back to machine learning. These authors, including Harlan Krumholtz, who's a frequent contributor, very prolific researcher.
Hey, Harlan.
Fan of the journal, I guess.
Yeah, well, he's on the editorial board.
Of course, yeah.
Yes.
That counts as fan.
Okay.
I would hope.
Yeah.
So he's senior author, and they try to use machine learning on a national database, the National Cardiovascular Data Registry, to model the risk of bleeding after PCI, and compared it both to the actual risk as well as to two other kind of conventional scoring systems. It was from 2009 to 2015, 3.3 million procedures.
I know. That's a lot of PCI, a lot of stents.
We do a lot of CATs in America, it turns out.
Yes.
4.5% have major bleeding within 72 hours. And basically the C statistic was pretty good at 0.78, which was slightly better compared to the two conventional measures, with a little bit higher sensitivity, detecting almost 4% more, and identifying like 1 point more who were fewer risk, with so slightly improved false negative rate. Overall, it was a marginal improvement. I think this is one of those things where what we see with a lot of these machine learning papers is it's like a little bit better or than regression. It's like super regression.
Yeah, except I would take out machine learning because what we see with a lot of methods is kind of small increases. The C statistic, as these authors acknowledge, it's a statistical finding. It's it measures discrimination. I think we've talked about this in a prior broadcast. It talks about the probability that if you had two patients, one with bleeding, one who was going to go on to have bleeding and one without, what proportion of the time this set of information would help you correctly predict which one is which. But that's not what happens. Patients don't come through the door in twos, one with and one without. So there's not a clinically intuitive measure. What I'm used to is a risk reclassification. So you add new information to the existing information and see whether it more accurately assigns people into their risk category of having or not having bleeding. And these authors did something different. They did a data-driven, patient-specific prediction ability, patient-specific predictive ability with a kind of a data-driven threshold. But to be honest, they set that up, and I didn't fully see the findings in that. So maybe that's in the supplement, and they describe an F statistic, which is the harmonic mean of the predictive value and the sensitivity. So this is all method speak. So I think they went in the right direction to give us clinicians a view of what this really means in terms of decision making in the ED or in the cath suite. But I'm not quite sure what came out of it, except to conclude, as you just did, that it's maybe a modest improvement, and I wasn't sure. I think this is probably more of a research paper than a clinical decision-making paper.
Yeah, and I'm always of two minds with stuff like this. Things like machine learning, AI in general, et cetera. We need to make a lot of fumbles, a lot of baby steps before this stuff's going to be widespread everywhere. And so on the one hand, I've heard a lot of people describe machine learning prediction as basically like not much better than regression, and there's been a bunch of kind of big studies that show that in meaningful ways. The flip side is, anytime we look at, or lots of times we look at things like diagnostic ability, prognosticability, et cetera, we look at it as a whole and say, oh, it's no good at all. But of course, things aren't like. As a whole, things aren't good. Like a CBC is not good if you look at it as a whole across all patients in an emergency department. It's helpful in certain patients with certain questions, and there's ways we can ask those questions. And I think the way you're describing getting the marginal benefit from the test over what we already know is the most useful way.
Right. And, the fact is that basic variables like age, sex, history of a prior heart attack, those do most of your work in terms of setting somebody up. And so it becomes harder and harder, like you reaching that kind of marathon finish line, to actually close the gap and say that additional information is actually going to give you a big boost toward the end.
Exactly.
But given that we had a call for machine learning papers, I predict, and you can talk about my accuracy, that we're going to see more of these papers on this broadcast and in the journal.
Quite possibly. We might be able to set up an algorithm that figures that out.
For example.
It's
called the Mike Index.
Right.
Okay,
Right. Another one for you to talk about more. The association of survival and immune-related biomarkers with immunotherapy in patients with non-small cell lung cancer, a meta-analysis and individual patient-level analysis. Basically, in really simple terms, they did a meta-analysis of immunotherapy for lung cancer, about 14,000 patients in the studies, and found that overall, for all the patients getting some form of immunotherapy, including immune checkpoint inhibitors, tumor vaccines, cellular immunotherapy, and some other stuff for non-small cell lung cancer, there was actually better outcomes with a hazard ratio both for overall survival and progression-free survival of 0.76. And I always love it when stats match up. I don't know why, but it just seems nice.
So the bottom line is that these immune checkpoint inhibitors are improving long-term survival on the edge of the survival curve.
Immunotherapy in general, which includes immune checkpoint inhibitors.
Okay. Got it.
Yeah.
Because I did look at this. These were all new concepts for me, and I had the proverbial or the illustrative bird circling my head after I read this a few times.
Well, for starters, you were looking at the wrong paper.
Okay. Okay. Very good.
There were two immune therapy ones this release.
Okay.
The other one was very good too. We're just not talking about it.
Got it.
But but basically you looked at it and it's good. My guess, again, like the aortic stuff we keep talking about, is that it's mostly about patient selection, getting the right things, using, finding the appropriate patient populations who get that marginal benefit from the new advanced thing, and not just, immune checkpoint inhibitors for everybody.
Got it. And we have a comment from TRAE Pendergrast.
That's Tricia. She is a colleague.
Hey,
She's
Tricia.
a former researcher and now a med student at Northwestern Med School.
Hey, awesome.
Who
Welcome to the tribe.
Understands the 3:30 p.m. snack urge. So the by purchasing food and calories outside,
but
outside of the cafeteria.
We need to establish some choice architecture in the vending machines at Northwestern.
I know, that's why I'm sad that our colleague moved her desk away from ours, but she also kept snacks there, so now it's easier for me to avoid them.
Correct. Yeah.
Great. Last couple comments on there. They looked at a couple different things. Basically, they found that I'm gonna butcher this name, but pembrolizumab.
Pembrolizumab.
Yes, plus a platinum chemotherapy, which I guess is one of the leading types of immunotherapy, did very well. And that all sorts of different markers such as PD-L1, TMB, and CD8 T cell tumor infiltrating lymphocytes were accurate in their predictive capabilities.
Awesome.
And now I'm going to not say those words again for many years.
Okay.
All right. Next up, back to something that I know things about and can pronounce words, maybe. Access to primary care clinics for patients with chronic pain receiving opioids. So these are researchers who looked at about 200 Michigan clinics, did those cold sequence secret shopper calls where they had a Confederate who pretended to be the child of a patient so that they could kind of blind, sex on the phone and things like that, and ask for an appointment. They only took clinics that were accepting both Medicaid and private insurance, so that wasn't a confounder. Randomized the clinics to receive a patient who was either ostensibly on Medicaid or private insurance, and said, hey, I want to get this, established primary care for my parent. Oh, by the way, they take chronic opioids for pain, and basically try to characterize what fraction of clinics would essentially not take them as patients. And the answer was that 41% of patients, or 41% of clinics would not make them appointments. 40% or 42% would make them appointments. 17% asked for more information. Most of those went on to then say, well, we'll make you the appointment, but it'll be up to the doctor whether or not to prescribe, which makes sense.
That's surprising, right?
A little bit.
I mean, it's certainly damning by implication. We don't really know what it means. What conclusions do the authors take from it?
Yeah, well, part of it was that the overall rate of clinics accepting new Medicaid patients was 54%, so this is a step down from there. The one thing, I guess one glimmer of hope I found here was that there was no difference between the Medicaid and private insurance here, so there wasn't like a double hit, which we usually see in vulnerable populations. But
were these really children calling? They weren't, though.
No, right? They were like adults, adult children of.
Got it.
Fictional adult children of fictional adults with opioid use disorder or with chronic opioid pain.
Okay. Yeah. One wonders whether the receptionist or whoever's picking up the phone sensed that something was off about the call because this is an impersonator. So there might be a confounding thing, but okay.
I don't know. I think you're looking too far into that one.
Okay.
What do you got? People do this usually pretty good. They do some sort of training. They did 100 calls each, or to each clinic. They're good at this stuff.
Okay.
I mean, I sound like I'm faking when I'm on the phone for real. So, all right. Last one we have another. This one's kind of an interesting one. So, exposure to court-ordered tobacco industry anti-smoking advertisements among U.S. adults. So, in 2006, there was a U.S. District Court case. And there was a court order for the tobacco companies have to make corrective statements through advertisements they pay for to make up for the fact that they'd been misleading the public for decades and making false claims. So what these authors did was survey 3,500 adults, mostly urban, 450 of whom were smokers, and tried to see, did you see any of these ads? About 40% of all of the of everybody in the sample did see the ad of some sort. I can't say I ever have, but I don't really watch TV with ads anymore.
Right. And do we know what the ads are? I looked for the examples and I didn't see those.
No, I didn't look that. But about half of smokers reported having seen the ads. Of people who had seen them, 70% had seen more than one ad. And then there were some just kind of interesting subgroups. The groups that saw the ads least were the youngest, so 18 to 34-year-olds, who probably, my guess would be less likely to watch broadcast TV with advertisements.
Right.
Lower education, lower income.
But these are billboards too, or not necessarily?
I don't remember.
Okay.
I don't know. But it's just interesting to me that I don't know. But a lot of people, I don't know, nearly half, at least 4 out of 10 people were seeing these, which I would imagine is supposedly in proportion with who was exposed to ads in the first place.
Right, but it seemed like the population most at risk for both smoking and not seeing ads, if that makes sense, are the ones who reported not seeing the ads, right? Maybe they're not watching a lot of TV or looking up at billboards, and they're kind of in their own. They're the younger ones. They're people who had a heavy habit, right, or something.
Right, but the smokers overall, the smokers saw ads more than non-smokers did.
Okay.
Which is good. But I guess I would also imagine if I were a smoker that if I watch TV and want a cigarette, ad breaks are a great time to go outside and have a cigarette.
Right. And we published something in JAMA Internal Medicine, I believe, about the Australian approach to this, which is to put these really graphic kind of gory images about the real health harms of cigarettes right on the packages, so you can't avoid it.
Yeah,
so that's really distasteful and repulsive.
Yeah, and I'll be honest, I haven't seen the actual data, but I've certainly seen some like secondary or years ago seen some lay press coverage of it. How apparently the pendulum might swing too far, and that stuff is like so horrific that people just kind of don't even think about it.
Right.
It's kind of you need to find that happy mayonnaise medium.
Yeah, I think this internal medicine study reported that it was effective, but I'm a little fuzzy on the details.
I mean, again, I'm vaguely remembering something I read in the lay press many years ago.
But go to JAMAnetwork.com or JAMAinternalmedicine.com and search for Australian cigarette warning labels or warnings, and you'll come up with that paper.
Yeah, so that's it for
Okay.
this week.
Great.
Of course, find these papers and more for free, open access online at JNO.com. Join us next week. I think we're back to Monday at
I
2
think
p.m.
we're back to Monday at 2
Monday,
p.m.
2 p.m. Central Time. Join us again. Of course, you can watch this video on YouTube, Facebook, and Twitter. Where, I always forget that one. I don't know why. Again, I've been exposed to it too much.
MD not aware.
Yeah. And now you can also download or listen to the author interview segments of these on podcasts wherever you get them, iTunes, etc.
Right, and subscribe to our podcast. Check out our new releases, which now I think we forgot to shout out is now on Wednesdays and Fridays. We're getting so much good stuff. We're doubling up in the week. So Wednesdays at 10 a.m. Central Time U.S. and Fridays 10 a.m. Central Time U.S. Check it out. Sign up for our emails, and we'll see you next week.
Yep. Thanks for joining us. Take care.
Thanks. Take care.